Greetings, everyone. My name is Ben Domalaon with student number 20166625. I'm a second-year nursing student from Western Sydney University. Before I start my presentation, let me share you my screen. I am here to present a case study about a patient suffering from COPD, also known as chronic obstructive pulmonary disease. Here is a brief detail regarding the patient. A 74-year-old female patient presented in ED with severe breathlessness. She was diagnosed with COPD 5 years ago. Upon admission, an A to G assessment was conducted and she presented several clinical manifestations related to COPD. The purpose of this presentation is to provide a detailed explanation regarding one specific clinical manifestation of COPD and its pathogenesis together with one high-priority nursing intervention to outstrip the clinical manifestation. Before we delve into further details about this case study, what is COPD? It is a progressive lung disorder that causes the bronchial tubes in the lungs to narrow, making it difficult to breathe. Some risk factors include genetics, environmental, and smoking. Approximately 1 in 7 Australians aged 40 and above have the disease. However, an estimated 1/2 of those who suffer from COPD symptoms are unaware of their condition. COPD is America's third leading cause of death, and it is ranked number 4 globally. COPD has no known cure, and thus the rate of deaths from COPD yearly is on the rise, both in the United States and worldwide. The amount of energy needed for the body to oxygenate the lungs is known as breathing. For the ribcage to broaden when inhaling, energy is required. Lung expansion, compliance, and resistance in the airways all influence the quantity of energy required to breathe properly. As the name suggests, the chronic obstructive pulmonary disease is characterized by a combination of narrowed airways and bronchoconstriction. It takes 10 to 12 times more effort to breathe for those with COPD than it does for those with healthy lungs. One crucial clinical manifestation of COPD related to the case study that I want to talk about is severe dyspnea. And I found out that it is interrelated with some other symptoms the patient has exhibited. COPD is characterized by airway obstruction that is irreversible during forced exhalation. As a result of overproduction of mucus, mucosal edema, and bronchospasm, the elasticity of the bronchioles is lost, and airflow obstruction is inevitable. Other critical factors of dyspnea are hypoxemia and hypercapnia, as it may develop over time, causing bluish tinge in the skin, and polycythemia. Polycythemia occurs when the body attempts to compensate for chronic hypoxemia by producing more red blood cells. And the last area to investigate is that COPD is also associated with failure to exhale air. Because of the narrowing of the periphery of the respiratory tract, the air becomes increasingly confined during expiration. Since the respiratory muscles are unable to operate normally, the chest hyperextends and takes on a barrel shape. It is important to note that if this clinical manifestation is left untreated, a further complication may result in pulmonary hypertension, or what we call cor pulmonale. Cor pulmonale is caused by high blood pressure in the lungs. As a result of alveolar hypoxia and acidosis, pulmonary hypertension develops in COPD patients. Because of this, chronic hypoxia leads to polycythemia. This increases the blood's viscosity. To push blood into the lungs, pulmonary hypertension causes an increase in right-sided heart pressure, which leads to right-sided heart failure. Now, I would like to draw your awareness to the pathophysiology that leads to the clinical manifestation. Toxic particles and chronic irritants such as smoke, dust, and fumes are inhaled and cause the inflammation process to kick into overdrive for the body to fight off these foreign particles. It releases inflammatory cytokines such as neutrophils and macrophages as well as lymphocytes. In COPD patients, these irritants trigger an amplified inflammation which damages the lung parenchyma and interferes with the cellular repair process, which results in airway edema, obstruction, and excessive mucus production, which contribute to the narrowing of both inspiratory and expiratory airways. Due to occlusion of the peripheral bronchial tubes, the air becomes increasingly trapped during expiration, resulting in dyspnea. Dyspnea triggers several COPD symptoms, including hypoxia due to decreased oxygen flow, hyperinflation of the lungs due to ineffective respiratory muscles, and increased respiratory rate since the lungs are compensating for decreased oxygenation. If left untreated, patients with COPD will resort to severe capillary injury and marked vasoconstriction from chronic hypoxia. They could develop respiratory hypertension, which is precipitated by right ventricular enlargement, hypertrophy, or dilation as a byproduct of lung disease. Deep breathing and coughing exercises are intertwined with correct repositioning as a high priority nursing intervention for patients experiencing severe dyspnea as a clinical manifestation of COPD. To get rid of most secretions, coughing is the most efficient method of doing it. Deep breathing exercises improve oxygenation before controlled coughing. As a result of coughing being done at different intervals, controlled coughing techniques help move secretions from tiny air sacs to the bigger ones. Because of increased abdominal pressure and upward diaphragmatic movement in a sitting position, coughing is more productive. Ambulation facilitates lung expansion, induce secretions, and minimize atelectasis. Abdominal contents cannot push upward and obstruct lung expansion when you're sitting upright. In this position, the lungs expand more, and the air exchange is enhanced. Using tripod position and pursed-lip breathing reduces the amount of work required to breathe, as well as number of calories and oxygen consumed. Tripod position involves relaxing arms and shoulders on the overbed table with hands together in a triangular shaped base, moving slightly forwards to maximize diaphragmatic exertion, and resting feet on the floor or a footstool to support the body. And lastly, to reduce the risk of developing pressure ulcers on the sacrum and buttocks when positional dyspnea is predominant, use pressure relieving and shear relieving techniques. In conclusion, COPD is a debilitating condition. As nurses, we need to care for us and support the management and prevention of patients with COPD. There is no doubt that as the prevalence of disease grows, nurses need to educate the patients and help them overcome this disease by providing therapeutic relationships and promoting self-management. That is the end of my oral presentation. Again, my name is Ben Domalaon, and thank you for your time.